We have a small group here, so why don't we do some introductions? I'm in the audience. Hi, I'm Jay.
Hi, I'm Hobie.
Hobie.
Yeah, I'm a psychologist
For UK.
in UK. University.
Nice. You're a professor there? You're a professor there?
I'm an associate professor entitled. I teach some of the medical residents on occasion. Mostly I'm working with directly with patients, psychotherapy.
Right. Very good. Okay. And online, we have Greg and Marie and Nicole. You guys want to introduce yourself, unmute yourself, and say hi? Tell me where you're working.
Hello, I'm Marie Vanderkoy. I'm from Grand Rapids, Michigan. I have a background in clinical informatics and I'm certified in telehealth. I teach graduate students, and so I work on implementing telehealth in practice settings.
Great to have you.
And Jay, you have to speak into the microphone for us to hear you.
Great to have you. And looks like anybody else want to introduce themselves, Brian or any of the others online?
Hi, I'm Kalyan Mupwarapu. I'm a clinical faculty at ECU. I'm the medical director for North Carolina statewide telepsychiatry program. Good to be here.
Very good. Brian or anybody else online want to introduce yourselves?
I'm Brian Myers. I am the Assistant Director of Behavioral Health at Appalachian Regional Healthcare.
Okay. So I thought we were going to attract some a fair amount of professors here. It looks like that's coming true. Anyone else want to introduce yourselves? All these shy people.
My name is Nicole Taylor Dosses. I'm a clinician with the Eastern Shore Community Services Board.
Great. Nice to have you. Are you training clinicians?
So I'm a resident in counseling, but I am certified as a telehealth provider.
When you say certified, where's your certification? Just curious.
I'm not 100% sure what the organization was that we got it through. It was I believe it was through North Carolina, somewhere in North Carolina that we got the certification. Bev, I don't know if you remember.
So she's calling me out. I'm Bev Turner. Also, I work with Nicole with the Eastern Shore Community Services Board on the Eastern Shore of Virginia, a clinician, licensed professional counselor, and also a crisis intervention pre-screener. We were awarded a grant that provided telehealth, telemental health certification, which we took advantage of. And then this opportunity came up for earning some, hopefully, CECs, and also to learn more about it as it's such an up and coming way to provide services.
Okay. Was it the board certification in telemental health through the Center for Credentialing and Education?
Yes.
I like that one. Great. So we'll get going here. I'm going to introduce myself and Ray Barrett. Ray's co-presenting with me. So I'm Jay Ostrowski, and I'm a licensed professional counselor, licensed supervisor. I started seeing clients in 2005 with a little IP camera, really grainy video. I'll come back to that in a minute. I work with, I've had my own private practices and work with large networks creating their private practices and running things there. I now work with adaptive telehealth, where we're making software. It's half of my life. And then the other half is with behavioral health innovation, doing consulting and training in telehealth space. I do a lot of work with the MATRC, the Matrix. We run the website and the Telebehavioral Health Center of Excellence. So I'm trying to kind of add to the body of knowledge, collecting research and making new programming for telemental health, telebehavioral health. And then also doing training, but also working on the pioneering the software side. So I like to wear a lot of hats. Digital Health Innovation is the company that we're starting up now, that it's more the invention space. We're inventing new products and services and companies even. So I wear a couple different hats, but I love what I do. I love being able to help providers get the knowledge they need to do these services. And by extension, they're helping people get help. Ray, do you want to introduce yourself?
Sure. Yeah. So I'm Ray Barrett. Hi, everyone. Glad to be here with you all. And I look forward to the discussion and questions. I always enjoy that piece. I'm a licensed mental health counselor, and I am in Virginia. When I started my private practice 18 years ago, my very first client wanted sessions over the phone, which was good with me because I was already doing work over the phone as an executive coach, but I didn't learn anything about how to do that in graduate school or in supervision. But I continued doing telemental health ever since I opened up my private practice. So then some organizations, a hospital system, an EAP program hired me to do telehealth for them. So I did that. And then I realized that there was a real need for practical training in telemental health. So I started doing training about 10 years ago, started our training institute, which is the Telehealth Certification Institute. I founded that institute 8 years ago. And so we train behavioral health professionals throughout the nation on telemental health. We also provide consultation around telemental health. So we provide a lot of different courses related to telehealth, and I'm glad to be here.
Great, thank you. I've known Ray for a long time now. So I was just a little bit about my background in the training space. I had grown up and sold my clinics and was doing a lot of consulting and training, and I got hired by the National Board for Certified Counselors. And I was the director of the Center for Credentialing and Education for a while. And we quickly saw that my gifts are more in the research and development space, where that's my passion is to make things. And I told Tom Clausen at the time, we need to get rid of the distance credential counseling credential, the DCC, and replace it with something more modern. And that's where, I said, we need a board certification in telemental health. And that's where the BCTMH came about. So it took me about 3 years to make that credential. And it was a deep dive into all the current literature and multidisciplinary. When I finished it, I dropped the mic and did something else and resigned from CCE, MBCC, but I'm still a promoter of the credential and think it's a good idea to get credentialed. In general, it's an external validity that you know what you're doing. So I think it's a good thing. But what we learned in that process is that training was all over the map. I mean, there's just no consistency in the training. And so that was some of the impetus as Ray and I have continued to train people over the years. We have learned that there's training is not as easy as it may sound. It's not just telling, and we do a lot of telling instead of teaching. And so telling is having the PowerPoint presentation and kind of going through the slides and telling people what to do. And my experience with that is when people get the telling, they still feel really insecure about the doing. So I remember training a group of providers in a state, and they had me back about 6 months later, and it was a group of about 20 providers, really seasoned people. And I said, so how's this going? This is a follow-up, warm-up. And they said, we really haven't done any so far, 1 or 2 sessions. And I was shocked. I was like, you spent all this money having me out. Why? What's going on? And these very seasoned people said, we just feel really like not confident about all this. And come to find out, there's some research that shows that the confidence level of the provider is mirrored in the patient, in the clients. So if the provider has low confidence in their ability to do telehealth, then the client has low confidence in the telehealth experience, which I think arguably would be portrayed into the therapy experience in general. And so if your patient, your client is not confident in their provider, I would say the outcomes are going to be lower than they should be. I think that's probably a good, reasonable leap of logic there. So Ray and I have been training people for decades now. When I first started, I was asked by a missions organization to see a little girl in Indonesia that had trichotillomania. They didn't say that. They said, she's pulling her eyebrows out and she has no big patch of hair gone. And it's pretty easy to think what that might be. So I was excited. I always wanted to go to Indonesia, and they said, no, we want you to see her online. And that was the year before Skype came out. So it was really avant-garde. And I remember being really insecure myself. Like, how do we do this? What's the right way? And what's the wrong way? And can I do harm this way? Come to find out you can do harm. There are several ways you can do harm. And more so, there are lots of harm to you as a provider and to your practice. So I'm going to go through, we're going to set this up in a kind of interesting way. At least I think it's interesting. I'm going to start to be the bad cop, and Ray is going to be the good cop. And so let me make sure I can line up your slides here, Ray, or your visuals. So we're going to make it a little bit bigger so you can see everybody. There's quite a few people here. So the bad cop version, that means me telling you the bad news, and then Ray gets to tell you some of the good news. And then we're going to talk back and forth together because we actually get along great. We're good friends. When I created the board certification, I was looking around for somebody that could kind of keep the torch going and be the first trainer externally outside the organization. And I selected Ray because I had a lot of confidence in his ability and his integrity. So we share a lot of the same worldview as well. So let me.
And Jay, let me say, we're seeing a black screen.
Right.
It's a blank screen.
Let me get that going. So some of the bad news. First of all, learning telehealth is easy, and it's really hard at the same time. It looks really easy. You just turn on your video, right, and you just see people, and you do the same thing that you would do in person. It seems that simple, and in a perfect world, it would be very much that simple. But in reality, it is kind of hard. And what's hard is that there's different types of knowledge that you need at different times. So I usually batch my knowledge into three buckets. The first knowledge is kind of that background. What is telehealth and what are the parameters? How does this actually work? What's telehealth? And we, as mental health, behavioral health providers, we need to realize that we're one part of a larger system. There's a lot of other telehealth going on and healthcare going on, and we're not isolated in our own silos. We need to be working with other people, with other branches of the healthcare industry, so that there's a lot of collaboration here. And in fact, there's really good outcomes in those collaborations. So we need to think of ourselves not in a silo, but as a group. So what's the background? What's acceptable? What's not acceptable? There's a lot of research validating telemental health, telebehavioral health. So by the way, I talk about telemental, telebehavioral health in kind of interchangeably. A while ago, I was talking with some friends at SAMHSA and HRSA, and we were like, there's so many different terms coming out. And that's some of my really research early was, I did a survey of all the state licensure boards and all the literature, and I found 46 different terms for telemental health. 46 different terms. And now I'm up to 54, I think, that people keep making up the new terms. And the problem is professors. Yes, you guys here on the call are the problem, because you discover something new and you give it a new name. Well, it's not exactly new. It kind of fits in this genre. So there's like cyber psychology, e-counseling, i-counseling, distance counseling. It's all counseling done through technology. So as a group, as a bunch, we're calling it telebehavioral health to include everything. And then when we're speaking of telepsychiatry, we'll call it telepsychiatry. When we're speaking of mental health only, counseling only, we call it telemental health. But as a group, we put in their apps and everything under this roof of telebehavioral health. So when I talk about telebehavioral health or telemental health, I'm just including the whole bucket of stuff. So there are layers of information that we need. That first is that background information. And then the second is kind of your setup stuff. What do you do to pick a software? And you need to know a lot about security and things like that, technology, picking a right vendor, because I am a vendor. So I kind of know some of the inside scoop on what that's like. What are some of the the things you need to know to set up your policies, procedures. So that's kind of your background knowledge, your setup, and then your actual practice knowledge. What do you do your first session? What do you do subsequent sessions? And so when I made the board certification, I made kind of a grid of 16 best practices that are, collated from everywhere. And I said, you do these your first visit, these before your visit, these during your visit, these, in every visit. Some only have to do first visit. So, because we have these procedures that need to be integrated into our workflow, and it sounds really, really complicated up front. But once you do it and you create your little checklist and you go through your routines, it actually becomes pretty easy and pretty well done. The problem is that there are no two telehealth systems the same on the planet. When you've seen, the joke in telehealth is if you've seen one telehealth, you've seen one telehealth. So as a consultant, you go into a hospital and you see a telehealth system and you're like, I'm just going to copy what they do. And you find you try to do that and it doesn't work. And we'll come back to why it doesn't work. But reeling back a little bit, some of this background knowledge, again, is the compliance. So there are federal laws, there's HIPAA for healthcare information, and there's FERPA for the educational system. HIPAA, we find, is there's a lot of ignorance in the mental health space about HIPAA. We don't teach HIPAA as a general policy. We don't teach HIPAA in graduate schools, and we should. Because we have a lot of graduate students that are coming out into internships and they've never heard of HIPAA other than they signed some paper at a doctor's office. And they think it's some piece of paper that's given to you that you sign and that's all that is. Where it's actually a mammoth piece of legislation that has lots of expandable rules depending on how big your organization is, how complex it is, where your data is. So as a mental health provider, everybody, so what I used to do is when training, I'll say, how many people have done their risk assessment for the year? And I get these really looks like, huh? So a risk assessment is a mandated security protocol for HIPAA. Every provider should do a risk assessment every year. But most of them don't know what that is or how to do that. But that's a mandated rule for HIPAA. A lot of people have the misunderstanding that to comply with HIPAA, all I need is a system that says HIPAA compliant, some software that says HIPAA compliant, and then sign a business associate agreement with that vendor. That is not at all what HIPAA is. That's not at all enough to be HIPAA compliant. HIPAA is a complex matrix of administrative, physical, and technological controls and privacy policies. So you have the technological part, that's like encryption. But encryption is one of 92 different things that we do in healthcare security, 92. So I think about what are the other 91? How are you handling those? A second one would be a business associate agreement. So if somebody has encryption and business associate agreement, that's great. But what about the other 90 different factors? There are only so many things you can automate in HIPAA compliance. How do I know? Because I've tried it. This is what I do for fun. Jeffrey's laughing at me because he knows me. I try to automate everything I can. So I was able to automate 72 of the 92. But there are some things in HIPAA that require human logic, human reasoning, human application. So you are supposed to have policies and procedures of who is permitted to get access to the data in the system. There is that risk assessment that a software is not able to do for you because the software won't know where your router is or who has access to your laptop or what your configuration is at your home office. Those are just examples. So it's imperative that we get an education on HIPAA. So that's a lot of information on its own. So we have a whole course, and Ray has a course too, I think, on just HIPAA compliance for a clinician. And that HIPAA compliance is different between a clinician and an organization. We'll come back to HIPAA in a little bit. So the second part is the FERPA. So FERPA is equivalent to HIPAA. It's not as complex, but it's applied to the school districts. So if you're HIPAA compliant, first of all, let me back up on HIPAA compliance. The I didn't bring the slides here, but I should have on that. I have a little joke I do with my students when I train is I have a big board with 10 different logos, HIPAA compliant logos. And they all say HIPAA compliant, certified HIPAA compliant, or HIPAA compliant, all of them. And I ask them, which one is the real HIPAA logo? And they'll put number 1, number 4, number 6, number 2, number 9, number 8, number 7, and then I let them all get that out of their system. And then I say, none of them, because there's no such thing as a HIPAA logo. Human Services never came out with that. That doesn't exist. What people are getting sucked into is marketing. And I'm a healthcare vendor too, a software vendor. I put HIPAA compliant on mine too. Why? Because then people would go, I didn't see a logo. It's not HIPAA compliant. But the truth is that no software is HIPAA compliant. No software is capable of being HIPAA compliant. And if you read the fine print in every single software, because I've read most of them, not every single one, they will all say, by the way, we are not HIPAA compliant. We don't have to be HIPAA compliant because we're not a covered entity. Because a covered entity has to be a healthcare provider or an insurance company or insurance broker. So there's kind of a double-sided thing here where they say we're HIPAA compliant, and by the way, we don't have to be HIPAA compliant. So we need to be savvy shoppers in this space, but our population of providers is not savvy enough, it is not knowledgeable enough to know that there's a lot of marketing going on that doesn't mean that you're secure. So that's pretty important to understand, that you're entrusting your reputation and all your data to a company that's for profit, and they may not be telling you all the truth. So I made a while back some litmus tests, and I'm happy to send you that after the show, of what to ask, questions to ask your vendor, like how many PHI do you protect? And they'll say all of them. And they say, well, how many or where? And if they don't know that there are 18 PHI, protected health information factors, they're probably not protecting all of them, right? I had a lengthy, heated discussion with Zoom back in the day when we first started with Zoom, because I love Zoom, and they'll probably rip my license for saying this, but they're not HIPAA compliant. They'll say they are, because they're doing some of those HIPAA compliant things like other vendors, but they collect your IP address and they collect the patient's IP address, and that's protected health information. Because with that piece of health information, I'm able to identify that this is a mental health patient, because I can Google that IP address and find them. As soon as the information is attached to a healthcare provider, it becomes protected health information. And I got that from Health and Human Services, the Center for Civil Rights. I think Center for the Office of Civil Rights is the prosecutor for HIPAA. So they say, as soon as it hits your contact us page on the internet, that becomes HIPAA information that you have to protect under HIPAA. But most of our providers have something on GoDaddy or HostGator or something like that, and they're not protecting that information that way. So that's a heavy lift, though, to have professors and trainers get that well versed in HIPAA compliance. So I think that's kind of one example of the heavy lift to have anybody become a trainer in telemental health. And Ray and I are going to talk about some solutions about this, but this is just an example of HIPAA is pretty complicated. Another complication is the state laws. Sorry, I skipped best practices and those kind of things. So best practices, every profession now has their own best practices. And so I track counselors, social workers, psychologists, marriage and family therapists, addictions therapists, peer support specialists, psychiatrists, and nurses. And everyone now has their own set of guidelines and best practices. Where we got ours was a combination of all of those, and we took all of those and aggregated them together in different ways. But when we started the board certification, nothing like that existed. A couple of pockets had stuff here and there. But the best practices are a little bit different. So I don't think people get really in trouble for the best practices. The problem is they're applied very differently depending on the rest of the information that someone might have about HIPAA compliance or about how those regulations should be interpreted. A lot of them mirror the best practices that found in state regulations. And I'll come back to states in a second. You might have a corporate office like Jeremy's Array. You might have a corporate policy, right, of what's acceptable by your team to do services, what's not acceptable. So those people need to be mindful that there are federal laws, there are state laws, there are best practices, and there's your corporate policies. And they may be consistent or they may not be consistent. But when we're training them, we need to let them know that there are these different buckets of laws and policies, and all of them have to be abided by. The state thing is a bit of a nightmare. So I've been, and I'll cry a minute and then I'll come back. And so you won't think this is all about Debbie Downer. So I've been tracking the state laws in all the states for telemental health policy since about 2002. And I sigh because I would call up and talk to licensure boards directly because I couldn't find anything on their website. And the administrator would say, "What is that? Tell me what that is." And I would explain it and they'd say, "We've never heard of that." And I would just ask them to go ask their board more about it. And the board would come back and say, "We never heard about that." And that's, for me, what I did with that information is I started a training program where I started training the licensure boards. Through the National Board for Certified Counselors, I would have annual training conferences with them to say, here's what telemental health is, and here's the evidence of that, and here's the efficacy of that, and this is a good thing. And what we found is that a lot of them had only heard about telemental health in graduate school. So I did a poll. I have a bazillion LinkedIn contacts, at something like 15,000 or so at the time, and I said, where have you heard of telemental health? And the large majority said, we heard about it in graduate school, and it was heard about in ethics, and all it was said was don't cross state lines. And so the fact that it was only in ethics kind of puts that in that red zone, that orange maybe danger zone, and all that was said about it was don't cross state lines. So I think we've kind of trained up some people in this space to be hesitant immediately about this. And I think that's been kind of alarming for a while. So that the states have come around. They were getting better over time, slowly getting better about their policies. And then someone would come by and say, well, now you have to have an in-person visit first. And we were like, why? And the answers we would get literally were something akin to, well, we just didn't feel it was right that you could do all that online. That's literally been told to me by a licensure board member. And I was just shake my head, really. And so I started doing trainings called the evidence base for making regulations. So I would talk about how to use evidence to make the regulations instead of just how they felt at the time. And again, a lot of the regulators are well-meaning people, and they're either appointed or they're volunteered or voluntold to join these boards, but they may not have an education or background in telemental health. So we still may have that hurdle going forward post-pandemic because some of the licensure laws are probably going to revert back to the old ways. So we need to be out there educating and advocating for that. So I'll come back to resources in a little bit to help you with that. The other part is that every state has, because of the 10th Amendment, we have the 10th Amendment basically says that where there are no federal laws, the states are free to make their own laws. That's Jay's, Cliff Notes version. So they do that. They like to take control of their space, their domain, and they should. They're protecting the people in that space at that time. So because of the 10th Amendment, they will make laws about telemental health, saying basically that anybody that's physically located in the state at the time of services has to be, the laws applied to that person. So if you're outside the state and you are applying, you're trying to serve somebody in Kansas, for instance, then Kansas law applies. And it's not like a driver's license where it's more like driving laws where wherever you get caught speeding is where the law applies. It doesn't matter that I'm licensed in North Carolina, for instance. So because that we have, most states had a policy or some kind of guideline, but they called it something different. So we had 26 different terms a few years ago from the licensure boards. Some of them would have 3 or 4 different labels, terms for the same policies. They might call it distance counseling, or they might call it distance services, or telehealth, thank you, or telemental health or telebehavioral health, or they'll call it digital services, or something like that, or services not in person. So if you're trying to find the laws, it's been very difficult, even for us that know a lot about this. and then they may use several different laws, different terms in the same policy document, or they might have it in regulations and then have a special newsletter that goes out that's considered to be regulation, but they don't put it in regulation. So where you go to look for it might be a problem as well. So we had to contact every license board and dig out what they would consider the law in this area. So that's a long road to say that every state has the potential of different policies in the same state. There are blessed 12 states that have composite boards, where at least the mental health part, not the medicine part, but the mental health part are one board. So that one board will have a policy. There are other states that might have a different board for counseling, social work, psychology, marriage and family therapy, peer support specialists, physicians and nurses, and addiction therapists. So that could be 8 boards in the same state with a different policy. So you can see kind of the mess that we're in, and that's not going to get different very soon. When you say, well, Jay, there's these compacts that are coming out, and I'm like, I'm so glad for compacts. The compact means that you have the license, you have the ability to counsel or do psychiatry in another state. But it doesn't mean, it also means that you have to abide by the laws in that state. So you have permission to work there, but then you have to know what those are and abide by their policies, and they are different in every state. So I think for the foreseeable future, we're going to have a mess there. But that's part of the difficulty in training this is that's a lot of knowledge that the average professor in psychology doesn't have time to go get all that background information. So you're getting it here, of course. And then each age group has some differences as well. And I won't go into that much deeper, but parental consent is one of those where I look for parental consent, and the requirement to have parental consent is widely different in every state for telemental health and healthcare services in general. And then it could apply to whether these are services that are text-based services or video services or SUD or mental health, or who has to be your supervisor, what supervision is permissible, is telesupervision permissible? It is in some states and it is not in others. And then the application of all this in that green part down below, the application of this can change depending on if you're in a clinic or your client's in a clinic, or you're at home and the client's at home. So the early model for telehealth was there was one clinic that would reach out to another clinic, and they'd have a clinic to clinic session. And each of those clinics would have their own IT department that would run things. And so they were in charge of all the security, all the setup, and you had a clinical room talking to a clinical room. And then over time, we got, kind of wild there, and we started doing clinic to home. So we have the clinic IT department making sure the connections are good and everything's secure, everything's done well, all the policies, procedures, technologies in place. And then the client home, we would not have that. So we had to develop new policies of how do you secure the client's home or their connection? And then how do you make sure that the client is not overheard by somebody at the client side? And then eventually it got to, we have home to home. So we have, who's the IT person now? Making sure that everything's good. Now it's been delegated to the telehealth software or to the provider that doesn't know any better. And so that's where some of I think the dangers are coming in that we need to be paying attention to. And we'll address that again more and more. So that's the setting differences that can change over time. Ray, before I move on, do you want to add any more to that slide?
No, well, that's perfect.
Awesome. He's going to be a great partner. I'll just say stuff and he'll go, yep.
There you go. Confirmed. I confirm.
Thanks. That's fine. We'll come to you in a minute, of course. So there are other challenges, again, that make it complicated, right? So the technology, everybody has their own technology. So it's not like we could say, here's what you do with this one software, and this is the one that's secure. Early on, a lot of people would say, well, which software do I use? And I was actually hired by a couple of insurance companies to say, which one should we use? Which one should we recommend? So I made the telemental health comparison website to lead people. Here's the criteria, and here's what the vendors say about their own criteria. And I'd say, look at this spreadsheet online and pick your own. So the telemental health comparison was a good tool, but then you have to keep on updating it. We have to keep on updating it. But what it ended up doing was giving more providers a an overview of what's available and what to look for. And they didn't realize that there was a lot more, again, under that HIPAA. If you pop the hood on HIPAA and find there's a lot of other stuff under there that's not regulated specifically by anybody in the industry. But there are different types of security risks. One of the kind of funny or sadder things is I do a lot of consulting and I go out to these different locations, and I remember being at someone's location and they were saying, well, here's the software we have now. And we were on video with some other people, and they showed the password to get in to everybody that was on the video. And they were now, everybody on the video could have retyped that same thing and got into their back end and access to all their data, all the patient data. And I thought that was pretty awful security, if you will. So these are human factors that humans do. Another human factor was awesome is I was consulting at one site and I went to the restroom, and on the way to the restroom, there's a closet door that was open and there was a server stack. You know what those look like, the kind of black racks with all the fans going and everything. And I realized this is their server where all their protected health information, all the data is on. Olga's laughing at me for that. And they had a childcare center for autistic kids right next door. And the kids would go to the bathroom on their own. And I'm just imagining one of them with an ice cream going over there and sticking that in there and shutting them down. I'm also imagining my kid when he was 12. This is kind of a funny story, but when he was 12, he hacked the school district with the flash drive and could log in as the system admin for the entire district. At 12, there's a lot you can do when you're bored and you're a bright kid. It got him a scholarship to Duke, so it turned out okay. But he could have owned them. Somebody with that kind of knowledge. Don't YouTube, don't Google it, because if you're downloading those hacker tools, the thing I think it poisoned the well a little bit, at least slowed him down, was to tell him that every time you download a hacker tool, you are being hacked by a hacker, because they embed hacking into that tool to hack you. So, right, Olga, that's the game, right? So Olga knows a lot about programming and cybersecurity. So I think a lot of us don't know that. We don't have that awareness. You also get on a nice list that the NSA tracks as well. So don't be Googling hacker tools, but they're available and they're really easy to do. They're easy to use. And with a flash drive, somebody can own your computer, own your entire system. So if they have access to your router in your lobby or your laptop when you walked out of the room, they can own you with 15 seconds of a flash drive. So that thing where you see in the movies where they stick a flash drive in, that actually can happen. It's real. It's not hard, not difficult to do. So those are risks that we are not aware of. And again, some of them are not, they're not pervasive enough for us to be scared. They do happen. People's identity does get stolen. People do get hacked, and it hasn't happened maybe to you yet, but it can happen. It literally is Russian roulette, waiting on time to see what will happen. If you bought a router at home and you have not reset the password, you are easily hacked because all of the default passwords are online and they're free to access. So somebody can log into your router and get into your computer fairly easily. These are, again, just examples of things that it's a tall order to ask a professor to learn. And then the types of services that we have, there are different trainings we need to develop for adolescent therapy versus child therapy versus adult therapy versus senior therapy. You don't have the same expectations in technology and what they're able to do to get to a direct-to-consumer services that you would your average person that has an office job. So those technology capabilities and what they're able to do and their setup in their own home. Sometimes people need that tech check, that hand holding. Sometimes they can do it all their own. Those different types of services we're doing, these are awarenesses that we need to give people of how do you do that work with them. So the hour and a half, 2 hours that we're asked to do and training is usually not enough training. It's enough training to create awareness, but it's not enough training to create competencies where people are able to actually do these things. So again, we could talk about the personal nuances, and there are a long list of things that could go wrong. And when we do train, I know Ray does some of this too. We actually simulate things that could go wrong. And Ray has some great video of himself doing telehealth very badly, and it's fun to watch. But he uses it as a teaching aid of, hey, look how bad this looks and how unprofessional this looks. And I think when we look at outcome studies, I would love to go to the research and go, how many of these were poor telehealth? Done poorly, but still got a good outcome. And what if we did telehealth well and a good user experience? Would the outcomes be even higher? Because right now they're showing that they're roughly equivalent to in-person services. No-show rates are actually lower than in-person services. So I'm wondering if we had really good, fluid, easy onboarding systems, easy to use software, and well-trained clients and providers, a good support system, would our telehealth, telemental health be even higher efficacy and more easily embraced by both the providers and the clients? Ray, I'm going to give you the floor again. You want to jump in on those?
Nope, that's great.
Great partner. Thank you. So what are the consequences? There are a lot. I think there are a lot of scary HIPAA stuff. So the HIPAA police, are actually they're getting donuts for the next probably year, I would imagine, maybe half a year. But we were told that because of the public health emergency, of course, they're not enforcing HIPAA. They still asked everybody to comply with HIPAA, but they said we're not going to enforce it for this period of time. And that was really a good move for the industry because they didn't want someone actually literally dying of COVID to have to go through the motions of HIPAA compliance because their provider wasn't ready for that. They wanted to just get care to as many people as possible, as quickly as possible. So I think that was the right thing to do. Unfortunately, what it has done is trained a generation of providers to think this is easy and we don't have to have that compliance because we can do harm by identifying who our clients are on the internet. That information can be used against them to do harm. Their identity, if you're an executive and you're getting substance use treatment, or if you're a provider getting substance abuse treatment or substance use treatment, or in any public office, and your identity is connected with that service, that could be the end of your career and certainly damage your reputation. Now, some of us, I try to advocate that every good clinician needs a good clinician, every good counselor needs a good counselor. So I do think we need to be in treatment. I think this venue done well is the perfect way for us to get help. But we don't want to be doing harm to our clients by letting other people know that they're getting that they're getting help without their permission. What I do know is that some clients, if we're not able to help them in their need, if we're not meeting those expectations, they can feel tremendous abandonment if there's a disconnect in the connection. Or if we haven't set expectations in between sessions, and I'm sure we could go through a lot of stories of harm that can be done to clients, or we didn't talk about psychological safety of the space that they're in at their home, and somebody is listening in at home in their conversation and is manipulating them, or in some cases they're in the same room with them. I know in cultural competency training, we learned that in Appalachia, some of the clients want their family members to be there, and it's not a manipulative thing. It's not weird for them. They just bring the family everywhere, and that's normal for them. And so, do we do harm to the relationship by pressing that issue or feeling weird ourselves about it and learning that that's okay the hard way? So we can do damage to our clients by not onboarding them to telehealth well. They might abandon therapy altogether, or say, this isn't worth it. This isn't a good experience. I don't really want to get help anymore because of how we did this experience with them. So there's a lot of things like that. But what I think could be the worst thing is the damage to your reputation. And I think as a provider, if you're seen to be sloppy by another healthcare entity, that means that you may not get referrals from them. And that's the lifeblood of your practice, is to get referrals. If you have a HIPAA breach, if you've been hacked, you're required by law. If you have so many clients, like I think it's more than 500 clients, maybe it's 250, I forget the number, the threshold, you have to publicly post for 3 months on your website that you have been hacked. And that's not something I want to do. We've all had those notifications on TV and the radio that so-and-so was hacked, or in the newspaper they were hacked. And this is a real thing, and it can happen to you. And there are many behavioral health and mental health provider organizations that have had those breaches and have had done damage to clients that way. And their records are sold on the dark web. They go from anywhere from $10 to $25 per chart on the dark web. And they use that to do spear phishing and steal identities, or to create new identities on their behalf and get credit cards and start false credit systems and do harm to your clients that way and to you that way. So I think if you're seen to be not doing things properly or securely, as the healthcare industry gets more versed in this, mental health providers are going to be looked at as, someone that's not worth the risk. So I think we could take the other approach and be a leader in that field and say, here's how to do telehealth well. Here's how to do it securely. By learning this information, I've applied these protocols and policies. I've gotten secure tech, and I do these things in a certain way so that my clients are protected. Your clients feel safe. Your referral sources feel safe. Your staff feels safe, and you feel secure at night that you're doing the right things. So I think that's a big part of the reputation problem that could happen. If there is a problem, it will cripple you organizationally. I've had a couple of different people that I've worked with that have had their identity stolen, or they had a breach in their clinic, and it's tons of time, operational time. You have to take off work. You have to do a lot of investigation. You have to hire people to do forensic investigation to fix that problem and plug those holes. But I think, that is a lot of economic damage that's private, but I think bigger economically over the long term is that reputational damage. Because once you get a stain like that on you as a person or as an organization, it doesn't go away. You're that guy that did that thing, or that woman that did that thing 5 years ago. And so that people are just going to be hesitant for quite a long time. Of course, the poor experience, it just could lead to people dropping out of therapy altogether. And that could be really harmful. And then losing your license, of course, and getting sued. Those are things that we want to obviously avoid. So we have systemic problems too in our training, just because you wanted more good news. We have in the academic sphere and in the public sphere, there's kind of a combination. So I'm going to just talk through this real quickly. And we have, I put this in 5 buckets. We have programs, educational programs out there, and then some of them are institutional programs that have these policies, procedures, and trainings, and they may be archaic and old. They did the best they could at the time, but things have changed. Things iterate. All the things that I mentioned to you, all of them change over time, and it's a tough haul to keep up with them all. So these programs might be educating people in misinformation over time if we're not keeping them up to date. So that's why I'm a little worried when a lot of professors go, well, I teach telehealth, or I teach telemental health. I worry. I'm hopeful, and I'm happy about that, but I'm hopeful that they're also getting the latest data out there, and they're training their students that the data changes. So you need to train them. Here's today's version, and over time this data changes. You need to keep up with that to be a good provider. And then we have professors that struggle too, and I'll come to all this in a minute. Individually. So programmatically, we have some of that historic stuff where I mentioned it being taught in ethics class only. So I think as professors are getting more up to date, some of them are just technophobes and don't want to go there. And so as they're doing their supervision, they may have some personal issues with telehealth that may come out in this. Our current curriculum, the time it takes to make a curriculum is a long time. And by the time it makes it to a textbook and is published, it's old. Anything in technology that's in a book is old as soon as it gets published. Now, it's better than nothing, of course, and it's a starting place, but they either have to water it down to be so neutral that it has a longer shelf life, or it's highly relevant, but it iterates quickly also. So I think it's good to get principles and foundations on there, but there's also relevant new knowledge that you need to keep up with in the industry. And then, of course, if we have an old curriculum and we're teaching that to people and we think it's current, we could be passing misinformation and doing some harm to our students when we don't have the most relevant, most current information. Some of this, I think, is also a problem with our operations. We don't have a system to do, say, a virtual internship. So we just created a software to be able to do that. So let's say you have an internship when the pandemic hit, you had these in-person internships, suddenly they went away. And the only way to graduate was to have live internship hours and live supervision. And so that was a problem. So we had some clients that wanted to do a virtual internship. And so we don't have the operational wherewithal, and most of the graduate students, we don't have the operational capacity or setup to do a virtual internship. Or a virtual client, is there a virtual referral system where someone gets referred from the agency to someone else this is a good client for the student, and then the student sees them virtually, and then the supervisor can see their clinical notes virtually in a HIPAA secure environment, and like an EHR, not Google Drive or Dropbox. And then is there a way to record this video virtually, and then have the video uploaded to a clinical space where a supervisor can review their video, or the student can review their video without it being on their laptop, or in some Dropbox somewhere, or some unprotected space. So I think we need to be looking at, how do we invent our virtual care educational programs to be piloted and educating people to try things out and do our internships virtually. So the graduate school professors, when a student comes to a professor and says, okay, hey, I want to do this telehealth thing, what's the response of the graduate school professor? Do they accept it appropriately because they did the homework on that system and said, yeah, that's a good system? But did they ask the student, what are your policies, protocols? What's your crisis care plan when something goes wrong? What are the state laws where we're seeing the client, and are you abiding by them? That many times the professor doesn't know the questions to ask to empower or enable the student to do this work. So they may be accepting appropriately because they've asked those questions, or they might be accepting inappropriately because they don't know enough questions to ask, or they could be rebuffing and saying no appropriately because they asked the questions, or they might be rebuffing inappropriately because they're a technophobe, or they're really insecure, or they don't have the time to go over that. Or they don't have the time they don't know the questions to ask, and they're just not, real secure with telehealth on their own, let alone having their interns do that work as well. So this is a problem for the graduate school programs, but it's also a problem for students that have graduated. So they're in that first couple of years of licensure where they're a student, they have the kind of partial license. It's called something different in every state, but what is our system to allow them to do that and be supervised? And does every state allow that? So I think some of the work, and professors and clinical supervisors kind of have that sometimes it's the same person. In pre-graduation and post-graduation, it might be the same type of person, the same person. Are the clinical supervisors well-versed in how to do telemental health correctly, and auditing that student's work and doing that and training them how to do that? And are they prepared to do that work themselves? Have they done it themselves? So, Ray, I want to stop real second and ask, you do a lot of training on telesupervision. Did you want to add more to that?
Maybe I'll just go through my some stuff when you're finished.
Sure.
Yeah.
So I'll just quickly say, our students, again, have their own set of acumen. And if they encounter a professor that's hesitant and the professor doesn't know what they're talking about in the technology space, I think it could lead to insecurity of the student in the entire program. I think it's okay for professors to say, you know what, that's not my area of expertise. Let's call somebody and get an expert to come here and help you guys, because there are a lot of free resources for that. Like I'm a consultant for Matrix. I'm grant funded to help people do that. We do a lot of graduate trainings. I'm not saying that that's the way you go, but there are other free resources out there where the professor can say, hey, let's go get an expert. And that would keep the credibility of the program, and also have that ability for the student to not lose respect in the professor or the program because of maybe a nuance that the professor didn't like. And then there's just a lot of ignorance. The providers I have in two buckets. There's people that are doing telehealth now and people that will do it. They're either lack awareness, or there's some incompetency, or they don't have time or resources. And then some myths I'm just going to go through really quick is that they think if I can copy what my colleague's doing, then I'll be fine. But they may not know all that their colleague is doing to make that secure. And they may not have exactly the same setup. They usually don't have the same setup and same location. they might use what a large organization does without knowing that the large organization has a separate firewall or another protocol or a special configuration with the parent company or the vendors that they're using, or they may not know the IT department is doing something extra, or maybe a small clinic, they're just doing the best they can and didn't know that there was a problem, and there might be a problem there. So they might be copying what other people are doing without knowing, and just copying the problems along the way, thinking, well, they're getting away with it, I'll get away with it too. Or they just don't think about it because they don't think there will be a problem, or they think that encryption is enough. So I think we could do better, and I'm going to turn it over to Ray to talk more about that.
Sure. Excellent. Yeah. Let me start off by saying, some of the things I think you all are probably interested in is, by the way, Jay, you did a great job being the bad cop. So Jay did a great job. Like, what is the gap? What are the potential consequences, and what are the real needs here? So some of the things that you're probably interested in is, does training in telemental health work? That should be obvious, but I'm going to talk about that really quickly. So does it work? What should we train students on, and how should we train them? So first of all, it does work, right? I've been providing training in telemental health for 10 years. We trained over 37,000 clinicians. And from very seasoned clinicians to clinicians who just graduated. And they all say, wow, like they're really surprised at how much they've learned. So like in our reviews, our surveys, over 97% of the people that take our telemental health training certificate program say that it's significantly impacted their practice. But there was also some research done on that actually recently. Because of COVID-19, there was a practice that they provided training to 87 seasoned clinicians on telemental health. And these clinicians, they said it really made them feel much more confident. And because of being much more confident in providing the service, they're much more motivated to do it. But even though they got trained, they still said that they wish they had more training. They wanted more. So we have this experience all the time with the clinicians that we train. And here's a research study that shows that. So what do you want in a training? And again, I'll kind of be quick with this stuff, but you want it to be high quality. And I know Jay touched upon this. Telehealth really is a specialty that requires a lot of time, right? So we work with a lot of universities. We provide some sort of training to at least 62 universities at our institute. And some of the professors are like, yeah, we would have to hire a full-time person to really uphold that same quality that we want with our programs. In being relevant is super important. It's constantly changing, accurate, the laws and the technology are sometimes kind of complicated. And when I say you want a training to be comprehensive, what I mean is, the technology is going to be constantly evolving. So the way things look today are going to be very different than 5 years from now. But what you want is your graduate students, your supervisees to leave your program in a way where they understand the core competencies, so that when they come across something new, they know what to look for. They know when to investigate further, rather than just taking it on, saying, okay, I'm going to take this on, I'm just going to run with it. That's the really important thing. The stuff that I learned in graduate school, some of it I hold on to, but it's mostly about learning how to learn, knowing what to look for. So that's really key and important. So, you want it to be cutting edge and sustainable and so forth. So what competencies should clinicians be trained on? What are those core competencies? And these will evolve over time. So what we did is we have a certificate program. It's called the Telemental Health Training Certificate Program. And it covers what we consider the core essential competencies of telemental health. And where we get this from is from a lot of different sources. So this is what I would look at if you're putting something like this together. So one thing we look at is, what do the professional associations say? We look at the licensing boards, and like Jay mentioned, right, interdisciplinary. So we look at all the different behavioral health professions. What are they saying? They have practice guidelines, codes of ethics. The licensing boards have something to say about it. And there's some really good training organizations out there, and professional groups, et cetera, professional literature and research. But our students are also a great teacher in terms of what is it that they need to know about today in the workplace. So they're constantly bringing up questions. That's one of the great places of having a live training where you're able to have the interaction, discussion, and Q&A. So some of the organizations that have actually done the investigation into what competencies need to be covered in telemental health. And I know I'm speaking fast because we have a lot to cover that I'd like to get through. So the CCE, the Center for Credentialing and Education, which Jay mentioned, they've actually had a credential in telemental health for over 20 years, right? This is not new to them. And they've done a real big review update of all that. APA and ATA got together. And they co-created best practices for telemental health. There was an article that was written in 2020 where they looked at 5 different telepsychiatry guidelines for telemental health. And then the Association for American Medical Colleges, they put together a task force where they looked at competencies. So these are just some sources, right? So we put this on a spreadsheet. We list them out. This is the kind of thing that you might do if you are putting together a course for your graduate program. You'll be looking at what are the competencies that have been identified by experts in the field. What do our students really need to be trained on so that then when they leave our graduate program, they're ready. They're ready for today's world, which is telehealth, right? That they're going to be providing that. So the next thing is, again, just for sake of time, because I really like the discussion part of this, is how should training be provided, right? So there's training of faculty, staff, supervisors, like Jay mentioned, and also the graduate students. There might be people that are licensed, but they're still receiving supervision. So in terms of training, the way we've found that it works really well is we break up our full certificate program into 2 parts, because a part of it can be done online, and doing training online is very helpful because people could do it at their own pace. They can rewatch videos as they need to. So a lot of the legal aspects, technology, how to select technology, all that kind of stuff, people could take that online, on their own. That's fine. I find that doing the clinical skills through a live webinar is perfect, because they're learning the way that they're going to be providing services. So what we do is we'll teach a skill, then we'll put them into breakout rooms with each other. They'll practice the skill and get feedback, come back to the main group, discuss it, go back, practice another skill. And they learn a lot. So when you're doing telehealth, you want to be a good clinician, but if you're doing it through video conferencing, it's almost like you have to be a videographer. So like, how do you get the lighting right? That is difficult. Getting lighting right.
I wish I had better lighting, Ray.
Yes, I know, right? It's like a constant fight getting lighting. So knowing how to get the lighting right, the audio right, the gaze angle, securing your technology in your own environment, all those types of things is definitely a learning curve. I had telehealth visits like this. Actually, I had 2 in a row for my family where all I see is the top forehead of the provider, or the audio is horrible. Yeah. Yeah. So practicing those skills with each other is super helpful, and people really start to get a comfort level with it. So the next thing is, a lot of organizations, you might not be working with graduate students, but the clinicians that are working within your organization, you'll have a credentialing and privileging process. So part of the privileging process for people that provide telehealth is probably that they have to take a telehealth training so that they learn what are the procedures and policies of your organization. How do they onboard clients? What do they do in particular situations? All that kind of stuff. So you're going to give them a training, but then you also might give them a clinical performance assessment. So after they take the training, you'll do like a mock. You'll do a mock session with the client, and you record that, like Jay mentioned, and then you review it with that clinician to look for where's there things that need to be changed, a remediation plan for that clinician to be credentialed to do telehealth for your organization. You don't want the clinicians in your organization to be getting on video like I showed you, or just the hairline showing, or they have, their location's not private, or all these just simple things. They don't know how to handle difficult situations that come up through video. So there's the credentialing. Now, in terms of universities, how do you fit telemental health training into a university program? What works well there? The universities that we work with, what they'll do sometimes is they'll have, because there's two ways to think about it. You could have telemental health competencies, interspersed throughout the program. So when they're taking ethics or a course on law or clinical skills or whatever theory, or cultural competency, you can have telemental health interspersed throughout the whole program. Or you can have a comprehensive one course on telemental health. So telemental health does involve a lot, but it's not rocket science. It doesn't take forever. Like our certificate program is 15 and a half hours long, and it can be shortened a little bit. So some universities, what they'll do is they'll have it as an elective, and it's just a one course, about 15 hours, and the graduate students are really well trained. Or it'll be part of their practicum, or it'll be a lab that they do. So there's different ways that you can do it. I can say that the universities that we've worked with, they really like doing it as a one kind of unit thing. And then they also like having the clinical skills portion as that live webinar, so that the graduate students do get to practice the skills and really get comfortable with what they're learning. So now, one last thing I'll talk about is the supervision piece. So when you're supervising a supervisee, one of the things you want to look at is you're a gatekeeper, right? So one of the things you want to look at as a supervisor is, am I comfortable with this supervisee providing telemental health services? So to protect yourself and to protect clients, you want to define the supervisory relationship. Okay. So you might start off saying telemental health is not within the boundaries of this supervisory relationship until I approve it, right? Until I verify that you know what you're doing, right? That may or may not be reasonable according to your situation. But like Jay mentioned, having a checklist is really helpful when working with supervisees. So you walk them through the checklist. And a good way to do this is how I provide consultation, probably the way Jay provides consultation, is you pretend that you're one of their clients. Okay, so where do I find you? Look at the marketing. How do I register? How do I get the appointment? How do I get into the meeting? You go through the process as though you're a client, and you go through the checklist of the competencies with the supervisee. And then you see where they're doing well, where are the gaps, and you have a remediation plan. And it doesn't take long, right? So by the end, you're really helping them practically be competent doing telemental health the correct way. So that's one of the really practical ways that I would go about supervision. So for sake of time, because I think we end in like 4 minutes, if I'm right, Jay, I don't know.
I think we have a little bit of time. Go ahead.
Yeah. So, well, let's we can open it up for discussion and questions, or I'll just share some last slides. Just again, who we are. This is the steps to the evaluation, and just for sake of time, I won't go through them. But basically, it's It's the setup, and then it's the, having the first session with the client, the documentation, and the follow-up sessions, et cetera. So again, I'm with the Telehealth Certification Institute. And if you ever need any assistance, like Jay mentioned, just to talk about what you're doing, how it is that you want to set up training or supervision for those that you're working with, feel free to reach out. Jay and I both really like talking to people in this field, sharing information, helping people with these things. So, yeah.
Well, let me open it up. We have about 10 minutes-ish left. What questions do you guys have about training mental health providers or medical students even? Or any questions about anything that we said about setting up training or doing the actual training itself? Is it overwhelming or encouraging or nerve-wracking?
It makes me want to train.
Who said it makes you want to attend the training? Yeah. Any thoughts? Soaking it all up. Yeah. I will say, we don't want to belabor everything. There's a chat here. Let me just pull that up. And yeah, we can provide some sample things for you guys to, if you want to put your email address in the chat, we can send that to you, or I can connect with you guys in the audience afterwards. Ray and I are happy to talk with people about how to do these training programs. We think that probably the best model short-term for any program is to outsource parts of it to people like us, or there are other trainers too that really know the space very well. I would recommend picking an expert that's been an expert for more than 3 years, that wasn't a COVID expert overnight, because we've been doing this for quite a long time, and there's some history there that's important to know about. And some background and some thoroughness. And a lot of it is a history of things that have gone wrong. And because we are very much in the matter of, prevention. I have in one of my trainings I have a little bit of scary video that I show of a simulation of someone that's psychotic. And I made that for the board training. And it's a real thing that can happen when you're meeting someone for the first time on video for a mental health appointment. You never know what you're going to get. It is Russian roulette. So if you're thinking, well, I only see people that are kind of, have mild depression, anxiety, and that's all I see, that's great, but you don't know what you're getting in that first appointment. Even with a screening document, you don't know what that is. Or if you have someone that has a psychotic break or a substance abuser, a lot of that is that suitability of that client to you. And are you a suitable person for this client, whether telehealth or in person, really? So I think there's a lot to learn there. But what we want to project to you and propose to you guys is that when you're making these training programs, is that you're going to get to a point where you don't know something, and that's okay. That's where you reach out to Ray and I and other people to say, I don't want to tell you, student, that I have all the answers, but let me get that answer for you. And I know people that are experts. So we want you guys to get your training as professors and be confident. And then also know that you got some backing and you got more resources there. You don't have to know it all, because it's a lot to know. So, and I want to talk about it when we do these webinars in virtual, hybrid, in person, the lighting is just not good. So we got to talk about getting a light for a speaker, although I think it would be really hot here. It's already hot. But Ray, I've really appreciated having you on, and I don't want to belabor things anymore, but I meant to follow up on a story real quick that I started with. I had this group of people I mentioned that I trained them. I came back 6 months later, they still weren't doing the work. And I inquired why, and they said that they weren't confident. So the remedy that we had for that is we played crazy, and we played doing telehealth interventions with crazy people. That was their word. I don't mean to be disrespectful, but we had some of the counselors go in another room and then dial in on video camera, and then they played that they were mentally ill, One had brains coming out of his head. He was holding them in with a towel, and he had a shotgun on his lap. He was like just really playing it up, trying to think of the worst case scenario he could think of for his colleagues in the other room. And then his colleagues were on the video, kind of talking him down. And here's what I would do with this emergency situation. And we just sat and did this all day long with different scenarios. And what we found is at the end of the day, they had a lot of confidence of, I got this. I can do this. So I think that simulation work of telepresence, because once they're doing it and they're Dr. Forehead or Dr. Chin, where they're only showing their chin, or they don't even show themselves because I don't like to see myself on video. You have to get used to seeing yourself on video to give a good presentation to somebody else. Once we get that confidence down that we can do this work as professors, we're going to be confident to project that knowledge to our students. And then when we don't know something, it's okay to say, I know some people, let me get that answered for you. And I think it's okay to empower people of this knowledge is layered. And as you do anything new in telehealth, you should get a little bit of supervision or a little bit of consultation with an expert, because ethically, anytime we do something new, we're supposed to be getting a consultation and some supervision, because that's part of our ethics, that we get training in what we're doing. I think as things are evolving and you're going to get into chat or recommending apps or doing that kind of work, all of those have very positive things and dangers as well. We recommend getting some consultation or doing some lit reviews on that. There's some good ways to do those kinds of things. You want to be training your students that this is an evolving field and they need to be keeping up with the evolution if they're going to go into that field, or be aware of that over time. Right? Do you want to add anything to that?
Yeah, we have the same experiences as you do with when people that we're training do the practice piece, they feel much more confident. Like one of the scenarios that we do is an emergency management plan type situation. So the client's suicidal with plan, with intent, they're not cooperating. And everyone really enjoys doing that because they really enjoy seeing each other in action. And then also all the time we have students emailing us after they've been trained saying, hey, I'm working for this organization and they're doing things this way. I'm not so certain about this because I was trained a little differently, so they start to notice concerns and things that need to be looked at. Supervisors, professors, graduate students, they really walk away, feel much more confident, know what to look for. It's a great experience. As all of you listening, being professors and being in supervising, you have this experience. It's great to see people walk away from your trainings feeling much more confident. So yeah, we have that same experience.
So I just put in into the chat a resource we made a couple years ago that we keep up to date. And there's some consultation if you need free consultation. The Mid-Atlantic Telehealth Resource Center, part of this sponsoring the summit, put this together. So I do a lot of consulting through them, and we put together the Telebehavioral Health Center of Excellence, where we're pooling all the best information, vetted information out there. If you start Googling telemental health information, you're going to get a lot of old information because Google rewards what's old, not so much what's most relevant and current. So we try to keep those current resources, vetted resources there for you guys. It's also a good source to give to your students. And then if you want to contact us through that portal or other channels, of course, we can answer questions for you on telebehavioral health to help you guys get going. If you need some help with training different parts of it, maybe you're strong on one area, but you're not on another, Ray and I can help you with those parts to help you feel good about what you're doing. It also gives you a break as a professor, right? So, well, I'll go ahead and call it time. I'm grateful for having all of you on virtually and in person. Ray, of course, you're a great partner to have in many respects. I'm always happy to have you with us. So thank you so much for your presentation.
Thank you.
All right. See you guys.